Hi, Dr. Myers. Thank you so much for joining us on MD Newsline. Can you please introduce yourself to our audience?
Sure. My name is Dr. Alyson Myers. I am at Montefiore in the Bronx. I'm the Associate Chair for Faculty Mentoring and Community Engagement, as well as a Professor of Medicine, and I'm an endocrinologist by trade.
Great. So I read this awesome paper that you co-authored about diabetic foot ulcers in general. That's a topic that is extremely important, as a lot of people know. So can you tell me a little bit about the research?
Sure. So I was fortunate enough to get grant funding through the American Diabetes Association and from our Center from Diabetes Translational Research at Einstein to look further into diabetic foot ulcers and how they're impacting our health system. So the first part of the study was to do a 5-year retrospective chart review to look at the rate of amputations for patients who present with a diabetic foot ulcer based on ICD-10 codes. And so what we found is that in that study, there was about just under 700 patients, that 44% of the people when they came in the first time with a diabetic foot ulcer ended up with an amputation. Typically, it was a single toe amputation. We also found that the rate of readmission at 30 days was relatively high, as well as their length of stay in the hospital. So typically, when someone has diabetes and they come to the hospital, their length of stay on average is 5 days. We found that people who have diabetic foot ulcers, their length of stay is actually twice as long. It's 9 days. So that makes it something that's costly. That makes it something that's not great for the patient. And then they're going to have to do a lot of follow-up with the podiatrist, their internal medicine doctor, vascular surgeon, their endocrinologist. So it's really overwhelming for a lot of patients. Also, in terms of their care, sometimes they need IV antibiotics and wound care when they go home. That means having a nurse come out. And for people who have jobs where they're on their feet a lot, they're also told to not bear weight. So that also can further complicate things. So we just wanted to get a feel of how big of a problem is this, and then try to come up with solutions of how to alleviate this problem.
So this 44% amputation risk, how does that compare to other rates at other medical institutions or even globally?
So globally, right now, we have a serious epidemic with amputations. In fact, diabetes is the leading cause of lower extremity amputation worldwide, as well as in the United States. So this is par for the course. Our population is somewhat unique in the fact that we are about 90% African American, Hispanic, Latino, and that's representative of the Bronx's makeup. Also, majority of the patients in our sample were low socioeconomic status, and majority also had a high school diploma or less. So I can't speak in comparing apples and oranges, but for us, we were really disappointed to know that so many of our patients who do come in with that first ulcer are receiving an amputation.
And then when it comes to, so you've mentioned a couple of things that hint at the social determinants of health, for instance. Are there any factors that you think may be driving these rates? I'm thinking a little bit about maybe some gaps between primary care and, let's say, endocrinology or neurology and things like that, or even things that have nothing to do with the hospital system. What do you think is causing this kind of persistent rate?
So that's a really good question. One of the things that I like to do is applying the socio-ecological framework when I think about this. So first you're looking at it on the patient level, then you're looking at it on the provider level, then you're looking at it more on the institutional level, and then policy level. So on the patient level, when we actually did some interviews with patients, a lot of it was just not knowing. Like, people don't know to check their feet every day. They don't know what to look for. They don't know what proper footwear is. And for a lot of our patients, a lot of them are immigrants or second generation from the Caribbean. They're used to walking around barefoot or in flip-flops or chancletas, and not understanding and realize that when you're walking these streets in New York, they're dirty, they're rocks, there's glass. And when you have diabetes, very often you have nerve damage. So you may not feel if something like that gets in your shoe, whether it's a sneaker or a flip-flop. And so what happens is someone's walking, they're not realizing that there's this ulcer forming because of one of these things. Someone could step on a nail and it's going through their toe, but because they have this nerve damage, they're not feeling it. So very often that's what's going on with the patient. On the provider level, sometimes, unfortunately, we're dealing with implicit bias. And that means that sometimes our biases prevent us from giving the patient the best of care. So, for example, an older patient, someone may assume, oh, you're not going to be able to use diabetes technology, so I'm not going to offer you something like a continuous glucose monitor or a pump to help you control your sugars better. And that could then lead to that patient not getting the best glycemic control because we're assuming that they are not capable of doing it. The other issue that can come into play for us as providers is insurance companies. So I can write a prescription for what would be a great medication, but then I have to do a prior authorization, which could be a lot of back and forth in time. And at the end of the day, if the insurance company says no, my hands are tied, and I may have to then give substandard care to a patient. So those are some of the things on the provider level. And then we think about the institution. What's the access to care for our patients? So the Bronx, we have public transportation, but if you live on the west side of the Bronx, getting to the east side of the Bronx is not easy. If you live in the South Bronx, getting to the North Bronx is not the easiest, even though we have buses, subways, and some of our patients have what we call Assessor Ride, which is a transportation system for people who are older, who are unable to get around on their own. So, there's all these various things that come into play. It's not just one layer. You have to look at all of the layers, and that's how we can close this disparity gap.
Mm-hmm. So you talked about potentially coming up with solutions. Is that going to be in the next phase of the study, or did you kind of come across any potential solutions?
Mm-hmm. Yes. So in the second phase of the study, we did what we call qualitative interviews. That's where we interviewed patients and providers to get their feedback about some of the issues that come about when people have diabetic foot ulcers, when they're hospitalized and the transition home. The third part of the study was actually doing an intervention. There is a company called Podometrics that has a mat that patients can stand on daily. And what it does is it measures the temperature of the foot. And if there's a deviation from the norm, it could suggest that there's an infection brewing. So before the patient actually sees the redness, they actually see that their foot is swollen, you may actually be able to detect an underlying ulcer so they can get into care sooner than later. So there's a nurse that monitors the temperature changes. And if there's a more than 4-degree temperature change that is suggestive of the fact that there may be an ulcer brewing, they alert the patient to come in. So what we did is we did what we call a feasibility study to see if in our population, this mat would be something that patients would use. The study has been done before in the VA. It's never been done in a study in a population like we have in the Bronx. And it was interesting. What we did find out is that our patients actually used it more than some of the vets did. So there was actually good adherence by our patients to use it. And there were a few ulcers that were found early. So we actually have a poster here at Endocrine Society. One of our med students is presenting today, this afternoon, about the results of that.
And is that something that they need to have in their home, or do they go, I know there's like, for instance, at CVS, you can go and get your blood pressure checked by that machine. So is this...
Right. Yeah. It's a mat they keep in their house, and through Bluetooth technology, the data is transmitted. It looks like a foot mat. Yeah.
Interesting. So talk to me a little bit about maybe some of the cascading complications that come with having an amputation like that, and how an amputation maybe unfolds for a patient's life in general, health outcomes.
So good question. The natural progression, unfortunately, for a lot of our patients, it starts with a toe, and then it becomes a transmetatarsal amputation. So that's when they cut off all of the toes. And then the next step is usually a below the knee amputation. And in some cases, some people actually have to have an above the knee amputation. And once you get to the point of having an amputation below the knee, your chances of being alive in 5 years are actually 50%. So this is something we really need to focus on. If you lose a portion of your foot, your chances of being alive at 5 years are more like 70-something%, but it actually dramatically decreases. So that's why this is something that we need to be paying attention to. And it's why we need to empower our patients to know about what they need to do for foot care. And we as providers are making sure that we're providing patients with the proper screening so we can be aware of the fact that they have nerve damage and or good or poor circulation.
Yeah. So just looking at clinical risk factors and some laboratory markers. So elevated inflammatory markers like ESR, CRP, WBC, and low albumin were associated with increased amputation risk. How should clinicians integrate these laboratory findings into DFU management? And risk stratification in general?
That's a really good question. So typically these are markers that we check when people are admitted to the hospital. But even as in the outpatient, if you see a patient and you're really not sure how severe this infection may be, you can check these laboratory values. And if they're high, then that would suggest that they probably need to be sent to the hospital because they probably need a higher level of care as opposed to just giving them oral antibiotics and sending them home.
Hmm. So interestingly enough, HbA1c was not associated with amputation risk in your cohort. What are your thoughts on glycemic control and its role in DFU outcomes?
Yeah, so that's also a good question. Sometimes hemoglobin A1c can be a very inconsistent thing when we're looking at predictions of bad outcomes. And I think the issue is at the end of the day, when your sugars are well controlled, you're going to heal better. But if somebody comes in and they have good vasculature, they don't have severe nerve damage, and the podiatrist or the vascular surgeon can get away with cutting off just a small portion of the toe, because sometimes they might just cut off the tip of the toe or the toe itself. If they're able to get a nice, good, clean margin and it heals well, sometimes it happens when someone's A1C is not at goal, which is typically going to be less than 7%. There's some people that'll still heal well, even with an A1C of 9 or 10, surprisingly enough.
So you talked a little bit about the cascading effect overall, and how amputations can then lead to more amputations, unfortunately. Can you discuss the significance of comorbidities like peripheral artery disease, osteomyelitis, and other things like that?
Yeah, so typically what we've seen in our study, as well as in other studies, is that people who have other comorbidities from diabetes typically are going to be at more risk. So that would include renal disease. So that's someone who's on dialysis or someone has advanced kidney disease. And it's not surprising because most people with kidney disease have poor circulation. We know that PAD or peripheral arterial disease will definitely set someone up for an increased risk of amputation. And what you can do with that is if you catch it early, patients can have what's called revascularization. That's when the surgeon would go in either a balloon to open up the artery or can actually do a bypass. And that would allow for better blood flow. So if you have to give someone antibiotics to treat an infection, it's more likely now that the antibiotics can get to the area of the wound. We also know that patients who have retinopathy, that's severe blindness, may be at increased risk because they're not able to see the wounds on their feet, and that's going to be problematic for them. And so that's why I always tell people it's important that you or your caregiver check your feet regularly.
So on the topic of antibiotics, nearly all patients received antibiotics, but only a minority had access to advanced wound therapies or vascular interventions. What are barriers that exist to broadening the adoption of these interventions in underserved populations?
Right. So I think one of the key take homes is when you use antibiotics, antibiotics are not for wounds, they're for infections. So just because someone has a wound does not necessarily mean that they need antibiotics. Also, picking the right antibiotics is something that's important. We didn't publish it yet, but we found that most of our patients had MSSA as the cause of their infection, but routinely we're covering for things like Pseudomonas and other really big, using big antibiotics, stronger antibiotics to cover for things that are not necessarily causing your diabetic foot ulcers. So it's really important to look at where you are and see what are the most common causes, because you may be overtreating with antibiotics. In terms of access, access has a lot to do with where you live, your socioeconomic status. So studies have shown that if you live in areas that have a low index when it comes to poverty, you definitely will have more access to things as opposed to someone who lives in a higher poverty indexed area or an area of higher disparities. So I know one of the problems we've been having in the Bronx is that a lot of our pharmacies are closing. So before you might have only had to walk 5 blocks or 2 blocks to get to your local pharmacy. Now you may have to walk a mile or go further. And again, if you have an ulcer and you're supposed to be non-weight bearing, you can't do all this walking around. So that's definitely been an issue with access to getting medications, is that the pharmacy closures have been disproportionately affecting communities of color.
Your study highlighted the importance of multidisciplinary care. What models have you found most effective, and what are some of the challenges in implementing them in resource-limited settings?
Excellent question. So right here at Stanford, they actually were one of the first places to have a multidisciplinary care program, and they were actually able to decrease the rate of amputation. So they had vascular surgery, internal medicine, podiatry, a wound care nurse. And what they found is that when they brought people in, they did this early intervention. Again, this is this early vascularization. They were able to reduce amputations by like about 38%. And when I saw that, I was like, this is great. We need to do this because clearly we too were dealing with a high rate of amputations. So in March, we started our first multidisciplinary clinic. It's endocrinology, infectious disease, behavioral health, podiatry, and vascular surgery. We come together, the patient comes, we rotate between the rooms and we each see them individually. And then we come up with a plan and we follow them out for a year. So some people, you may want to see them back in 1 month. Some people, you can get away with seeing them back in 6 months. So pretty much we will take anyone who has an active diabetic foot ulcer, a chronic foot ulcer, or anyone with a foot deformity, because we know that if people have foot deformities, that's also going to increase their risk of developing a diabetic foot ulcer down the line.
And when you say foot deformities, are you just talking about regular bunions, or what are some of the more
There
common
are
ones?
all types. So bunions is definitely one. You commonly see it in especially women who wear high heel shoes, or men that wear improper fitting shoes for work every day. You can also see high arches over time that develop in people with diabetes, or something you commonly see in our folks is being flat-footed and you don't have proper arch support. So that also can set you up for getting ulcers. So those are some of the different, also forgot hammer toes, where your big toe crosses over your second toe. So those are some of the common deformities you can see.
And are those deformities things that people know to be an issue, or is it typically something that they've just lived with their whole life and they're like, being flat-footed never really bothered me, so...
Right. And that's sometimes the problem. When you have diabetes, because you don't have symptoms, you don't feel things, you think it's like, oh, no big deal, I don't have to attend to this. But absolutely. Because I saw a lady who had 2 humongous bunions. She said, oh, these don't bother me. I just put on my shoes. Or I have people say, oh, I just size up. But sizing up is not always right, because if you have too much space, your foot's going to rub. And over time, that bunion could turn into something more serious. So it really comes back to educating people. The other thing we have in our clinic is a podorthist. So he actually measures people so they can understand what size shoe they can wear. Most of us don't wear the right shoes. We don't realize it. And it doesn't matter if you have diabetes or not. A lot of us are not wearing the right size shoe.
When it comes to this multidisciplinary team, what are some of the things that you all might be doing that's different from the way a regular clinic is run, as far as record keeping? You all already mentioned conversation and just time management in general that you think would be an interesting thing that might be applied in different settings.
So I think the really most important thing is we're having real-time discussions. I can tell you, if I reach out to other providers, if I'm lucky, I get a response within 24 hours. But some providers, I have to nudge them 3 or 4 times before they answer. Some people are better at communication skills and time management, as you said, than others. So the fact that we speak in real time makes life so much easier for all of us, as well as the patient. I'll give you an example. We have a young man who has type 1 diabetes and he needed to get hyperbaric therapy. So that's when you're using high dose oxygen to try to help with the wound healing process. And he was using an insulin pump. And what I was unaware of until the podiatrist reached out to me is that when he goes into that particular machine, all machines are not the same. There's a 7-minute delay before they could take him out. So that means if he is in a position where his blood sugar is low, he would be stuck in that machine with a low blood sugar for 7 minutes, which is problematic. So we had to come up with a safe plan. Do you keep him on his pump? Do you take him off his pump? To make sure that if something were to happen, we can, attend to him. So it's conversations like that that are just so important to have in real time. And you don't always get that if you're not coming together regularly. So we have the clinic once a month, after every first Friday in the morning session, but we meet in between every other week. And we also have an email chain that we keep if something pops up in between.
So when it comes to patients post-amputation, considering this high readmission rate, how do you ensure continuity of care and follow-up for patients after discharge? So
really what's important is making sure that our inpatient team knows about our clinic, because when you come out of the hospital, you only have a month's worth of medicine. And some of our patients don't have a primary care doctor, or if they do, they're not getting in within that 30 days. So they may run out of meds. So a lot of times for me, it's refilling medications, whether it be their blood pressure, their cholesterol, their diabetes meds, because they only got a month, which is routine. There's nothing against the hospital team. That's what you usually do. to, but sometimes that access to seeing your PCP within a month is just not there. So I think that's one of the most important things, is getting these folks in within the month and making sure they have their refills, and then making sure that they're aware of their treatment plan.
So the study reported, we've already talked a little bit about readmission, but this 55% readmission rate within a year. When it comes to the primary drivers, are there any other primary drivers that we haven't discussed yet? Because we've kind of talked about what could happen, at the end stage. But what do we think is driving some of those things?
Right. So a lot of times, unfortunately, we can't really calculate the real number. I think the real number may be higher, because this is only based on people who were readmitted to our hospital system. So if they went to another hospital, we wouldn't be able to capture that. So I think the actual readmission rates are probably a little bit higher. But typically what it is that we're sending people home. They're not really sure what to do. And then we found that in the second part of our study. And it's like, unfortunately, things just kind of worsen. And very often it could even just be that they're coming back for a non-diabetic foot ulcer related. A lot of these folks have comorbid cardiac disease. So it could be a CHF exacerbation. It could be a worsening of their renal disease. So even though people were readmitted, they were not always necessarily readmitted for their diabetic foot ulcer. A lot of times there are other things going on, but some of these readmissions definitely were just the worsening of their wounds.
Mortality during the index admission was low, but increased by about 6% within a year. Even outside of that, how should clinicians counsel patients and families about long-term risk associated with DFU and amputation?
Right. So again, if you've lost your leg, unfortunately, within 5 years, only 50% of that group will still be with us. And a lot of it has to do with the fact that most of these people have comorbid cardiac disease. And so it's making sure that we're doing what we need to do to prevent cardiac disease. So it's the glycemic control, making sure that they're on a statin, and all the other things that come along with trying to decrease risk for a heart attack or stroke.
Are there any tools or kind of maybe points of communication and keeping up with people as far as like their support system or their primary caregivers? How is the community, family around them maybe engaged or not to help with the success of their outcomes?
So one of the things that we learned from COVID is that loneliness can definitely impact health outcomes. So if you have someone who's doing this on their own, it's going to be overwhelming, and they probably will not do as well as someone who's got supportive family. So I can tell you, in our clinic, we have several patients who come with their children, and it really makes a difference having their kid or their grandchildren involved, or their spouse, significant other. It definitely makes a difference. Like, for example, I saw a patient recently. I was doing a medical mission, and he said that his wife does all the cooking. And it was like, man, I wish your wife was here. He brought his son, but it's like, oh, man, I wish your wife was here, because you eat a typical island diet and there's a lot of starch involved. And that's why you're having a hard time controlling your blood sugars. So again, he did bring his son, and his son was able to hear and receive it. But at the end of the day, a big part of his diabetes plan is about his diet. And we see that a lot. So some people cook for themselves, but we often will have people who don't cook for themselves, or they rely on programs like Meals on Wheels to provide them with nourishment. So, definitely it makes a difference when you have a good support system, and when this support system comes to appointments and is integrated into the care team.
When someone isn't able to bring their primary support system to an appointment, what are some of the ways that we make sure that information makes it to them, or the conversation is had? And have you found anything that is more effective?
Right. So I think there's a couple of things. You can either call the caregiver if they're available at the time. That can help. We give the patient a patient handout, but I can tell you, even though I have an MD, that thing is not always the easiest to read. So you can give them the handout. But one of the most important things that I like to do is what's called the teach back method. So what it is that you're making sure that the patient can tell you in their words what they understand to be the plan and what they need to do. So I think that's really a great way. And it can be as simple as, when you go home tonight, what are you going to tell your significant other about today's visit? Or how much insulin will you take tonight, to make sure that they understand to adjust their dosing. So the teach back really will let you know, have you effectively, because you communicated, but did you effectively communicate so that they understand the plan?
So when it comes to access to care, your findings suggest disparities in access to limb-preserving strategies. From an advocacy place, what policies or system-level changes would you advocate for to reduce these disparities?
Right. So it means that insurance companies need to allow us to prescribe the medications that are going to be helpful. So these newer medications that are on the market have actually shown the ability to help with peripheral arterial disease. So those are the GLP-1 receptor agonists, SGLT2 inhibitors. But yet there's still some insurance companies that give us a hard time and don't want to pay. They want us to prescribe sulfonylureas, metformin, so that they fail first before they'll allow us to prescribe. So that would definitely be one policy change. If this patient has PAD, please allow us to use the diabetes medications that have shown and prove that they're good to help reduce things. The other thing I would say policy wise is screening. So I know that recently in the state of Illinois, there has been a passage of a bill to allow for coverage for screening for peripheral arterial disease in high-risk patients, and that would be covered once a year. So again, allowing us to not only give patients the right medications to help with this, but also to provide us with coverage to screen patients. We want to do preventive care before things hit the fan, ideally.
Are there any emerging therapies or technologies that you believe could also significantly impact DFU care and amputation prevention in the next couple of years?
Yeah, there are some things on the horizon. You know, there are people doing research on different salves and creams that can be used to aid with wound healing. Stem cells have also been proposed as a way to help accelerate wound healing. It'd be nice to see more access to that. And then also there's some socks that you can use, like I mentioned the mat by Podometrics earlier, but they're actually socks. There are companies that make socks that can be used to help predict changes. So I think if we have insurance carriers that will pick these things up, including the Podometrics mat, it's covered by some insurance, but not all. If we can see an expansion of coverage for these things, it would have a tremendous impact for our patients.
What unanswered questions remain, and what research directions do you think are the most urgent involving these patients with DFU and specifically in underserved communities?
Yeah, so I think that there was this really great paper around disparities in wound healing that I saw in a dermatology journal. And I actually wanted to do a study looking at, is there a correlation between melanocyte deposition and wound healing? I think that would be really interesting to look at. There is some belief that darker skin, and that doesn't necessarily mean black, because there are other people who have darker skin, but there's more drying of the skin, hence the fact that certain populations get more eczema. But is that, contributing to why we see this disproportionate number of DFUs in black and brown populations? So that's something that I would be interested in learning more about. And again, in the dermatology literature, it's still a Pandora's box. So it'd be nice to look into that further.
Interesting. How do you see? So we've talked a little bit about the mat, for example, that helps people catch ulcers quickly. How do you see technology, or how do you hope to see technology continue to be implemented to help people track their care and catch things preventatively?
Absolutely. I mean, it's also about the glycemic control. So more access to people getting insulin pumps and continuous glucose monitors is needed, and access to these things. But I just think we need to make life easier for people. Having diabetes is never easy. And I always tell my patients, you're in the driver's seat, I'm just in the passenger seat. You see me a few times a year and I'm here to help you. But I think we need to make it easy for people. We need to understand that some patients are not able to see their feet because of their weight, their mobility issues, their poor vision. And if we can come up with techniques to help people who may not have a significant other to look at their feet, that they could actually see. We tell them you can put a mirror on the floor. But again, if you have poor vision, you're not going to be able to see that. So working with these different disabilities that people may have to help make their diabetes care a lot easier would be something wonderful. So hopefully we can get funding for people who are working on these different modalities.
Mm-hmm. For clinicians listening, what are the top 3 take-home messages that you would say from your research that you would like to see them apply or keep in mind?
Although they say that we should only do foot exams at each visit for people who are high risk, I would beg to differ, just because I've seen people who are not necessarily high risk who come in with wounds. I had a man who came to me from a nursing home, and they were doing some sort of wound care for the past 3 weeks, and whatever it was, I could look at it and tell this is not healing well. Called my podiatry friend, said, can you get this guy in sooner than later? Sure enough, when she saw him 2 weeks later, she had to send him to the ER, and he had to go to the OR to get a debridement because his wound had gotten worse. Whatever they were putting on him at the nursing home was not working. So check everyone's feet at every visit would be my first rule of thumb. My second is empower your patients to see podiatry, to make sure that they're getting their toenails cut, to make sure that they're getting diabetic shoes if they qualify, and also just to get a good proper shoe fitting, because a lot of our patients are not wearing proper shoes. So it's a lot of good teaching that we can do. I typically do it while I'm examining their feet to show them things, and I will review this with them. And I even wear sneakers. I'm a model for them. So I'm flat-footed myself. I don't have diabetes, and I purposely will wear certain sneakers that are approved by the Podiatric Association, like Hoka, Asics. For my people who don't have big arches, I show them, you see the difference between my shoe and yours. So in real time, they can see. And I remember I have a nurse who's on 12-hour shifts in the ED, and just for her switching her sneakers out, she had leg and foot pain that was much better. For years, she walked around in pain because she was wearing the wrong shoes. Like me, she's flat-footed, and she switched out her shoes, and now her pain is so much better. So again, that education about footwear and how to look for bad things with their patient, so important. And then the third thing that I like to teach people that I actually learned from vascular surgeon is, just because someone has a palpable pulse, it doesn't mean they don't have vascular disease. They could still have PAD. So in the ADA guidelines recently, they have suggested that people over 50, people with diabetes for 10 plus years are high-risk people like end-stage renal. We should be doing a baseline screen. It's really important that if you're ordering the ABIs, which is our arterial brachial index, that you put in so that the tech knows to include the tibial pulses, because traditionally they don't include the tibial pulses, and that's where the disease can be for most people with diabetes. So I always make sure to write in when I send people for these vascular studies, please include the tibial pulses, because people can have severe disease there, and God forbid they get an ulcer, that can actually be really a problem.
How can doctors advocate for better care and outcomes for patients with diabetic foot ulcers in their own practices? Is there anything, even I know sometimes there's like nonprofit funding for maybe things that aren't covered by insurance, but then there's also other things such as maybe communication across disciplines and things like that. What are some of the ways that you'd like to see doctors advocate more, be more proactive?
I think one of the best ways you can advocate for your patients is to speak. So like how I'm speaking here today, how I spoke at this conference, and I put myself in rooms where there are politicians, and I speak to them about this to make them aware, because a lot of them are not aware of this. Even a lot of physicians are not. So really going out and speaking about this, being passionate about this, bringing it to people's attention, because this is not just a Bronx problem. This is a nationwide and actually a worldwide problem. So just speaking is the first place to start. Second thing, you can always write letters and call your local Congress people, your assembly people, and make them aware of any possible bills. You can always go to congress.gov and look for bills that need to be passed, or local bills, so, your city council, and bringing them awareness to, I'm Dr. So-and-so, and I'm writing this letter. One of the nice things is nowadays, a lot of our societies have a pre-written letter or template that you can use. So if you're not a great letter writer, which some people are not, you actually could just use a template for that. So I would say those are some easy things that we can do to advocate for our patients.
Perfect. Well, this has been an amazing conversation. Thank you so much, Dr. Myers, for joining us.
Thank you, Esther. I appreciate you.